Obviously, we're at a resort. These lifeguards are highly trained. It's not a lot of talking between them. They've done this. They know where they want their gear. They've reached the child. And the first thing they're going to do, obviously, with C-spine precautions, we're going to roll that child over, and we're going to see if that child is spontaneously breathing or not. This is a quick evaluation of how critical is this individual, what do they need us to do. Their number one priority, roll that child over, assess. Somebody will say, not breathing, no pulses, call 911. 911's been activated. This is what they trained for. Already, we've been activated. So Phoenix Fire, the closest fire station 32, is en route. We're reading now, we're getting confirmation from them. They're gonna start working with this child, but it's important for us to get as much information en route. And then native air, with the helicopter, they're gonna wanna make sure they have as much information so they can set that person up for success. So this is where all the work gets done. For the highest rate of survivability right now is we want to have that early intervention of that circulation, right? It always goes back to ABC, right? Airway, breathing, circulation. Do we have an open airway? Yes. He just said, no pulse, no breathing. That they understand now. What do we need to do? You're counting them through. Now we've got that oxygenated blood is moving through.
A really important consideration for drownings, especially this time of year, but any time of year, even 120-degree summers, is hypothermia management and prevention. So you can see right away they're drying him off, especially for a pediatric patient. We have to make sure that we're managing that wetness and thinking about body temperature.
Great teamwork right in front of us, right? Everybody's on the same page. It's almost comforting to know, and a lot of times we'll roll our lights all the way in. That way everybody knows we're here, we're close, you can hear how close we are. They're still focused on exactly what they need to do.
And so right now they'll just apply the AED to this patient. Hopefully we all know early defibrillation is a critical component of effective CPR and early ROSC. So getting that AED on as soon as possible is a critical part of achieving that successful outcome.
Rescue and Engine 32 are just arriving. There is somebody from this staff that's been on the phone continuously with 911. So the fire department is arriving, and what they know is we have a 13-year-old male, possible drowning, unresponsive, CPR. That's going to tell our folks, Phoenix Fire Department, paramedics, and firefighters, we're going to need to establish an airway. We're going to need to have continuous compressions. And now we're going to start thinking about, do we need to start a line? And do we now need to get pharmacology involved? And do we need to start thinking about epinephrine and all of our cardiac drugs when we have a respiratory arrest?
I think the thing that we can really appreciate with the way the lifeguard team is working right now is the importance of effective communication in critical incidents, especially a pediatric code. As a critical practice provider, I cannot think of anything more acute than a pediatric code. And so for this team to be working in unison like this is a really beautiful demonstration of effective communication in that team.
There's no rank at this point in time unless they've already established that. Most of the time, the person at the head is the person in charge. The person at the head is saying, don't move them, move them. If we're going to intubate, let's start that now. But that person, we have one person, you can't have multiple people that are going to be calling the shots. So here comes Phoenix Fire, and they're going to watch how they'll do the handoff and let them know what's going on with this patient. Our guys already have a good idea of what they want to do once they arrive.
When there's multiple teams coming in and taking over, each time there's going to be a handoff. So we need to give critical information. With drownings, important considerations are how long the patient was in the water temperature, and the type of water, because your fresh water versus your salt water versus your chlorinated water drownings have different management at the hospital. And so we need to make sure that that information continues down the line.
So if you look at these boxes, we have a drug box with all of any kind of medications, cardiac or anything we would need. We've got an airway box right here, so we've got our oxygen with us. we've got what we would call our trauma box. So it's got our airway kit. All Phoenix Fire paramedics and pretty much across the country, when you're a certified emergency paramedic, you're allowed to intubate, you're allowed to start lines, you can start central lines, we can drill, we're allowed to give all of our medications. Everything we do in Phoenix is offline. We have pre-established standing orders. We don't have to call for orders. In this case, we don't have to call for any interventions that would slow us down. We thrive on having our standing orders that our doctor has established that we are able to perform that ability. So now the helicopter is landing. I'll let Manny take it from here to explain what they're thinking about now. They're coming in on the helicopter, it's landing. They want to know what is going on with this patient and what's been done.
So anytime that a helicopter is going to be involved on a scene like this, obviously the helicopter needs some space to land, so we have landing zone considerations. For instance, our helicopter is just behind the pool here. We would need to know about any surrounding obstructions, like the tall trees or if there's power lines, because obviously our safety also has to be making sure that we get here so that we can help the patient. So coordinating that with the ground crew, they're going to communicate that to us as well as let us know what's happening on the scene. We have an ICU in the helicopter, so all their drugs plus some more. We have an advanced ventilator, we carry blood, we carry chest tubes, and we also carry an automatic compression device so that we can continue CPR in flight all the way until the handoff in the ICU, the trauma room, the ED, wherever it happens. So it's important for us to know what equipment we need to bring with us.
This is a critical junction in this evolution right now, but as you can see, this is a drill, but I'm going to tell you right now, I've been on this exact call right now. Everybody's on the same page. There's no stress. We understand what our job is. There's constant communication. We're evaluating the child. The child's condition is going to drive what we are doing and how we are doing it and the quickness of what we are doing right now.
So one of our team is going to receive a report, including all interventions done, all medications given, especially any of those ACLS drugs. When was his last epi? Have we delivered any shocks? How long has he been coding? That's all information that we need to know to make sure the hospital knows it, as well as to continue the most effective CPR that we can. Todd is the paramedic with our monitor on the ground, so we're going to just apply our monitor, and then any equipment that the teams have delivered, whether it's the lifeguard team or the fire team, we're just going to move over to our equipment so that we can continue that same or increased level of care throughout the remainder of the transport.
So when our crews were en route, we want to know the age of the patient. We start estimating what that weight will be. Remember, we're doing real-time math, right? We have to think about kilograms, how much epinephrine are they going to get, further weight. All of that is happening simultaneously right now. The full effort right now, again, we're still at airway, breathing, circulation, and now you just heard me said one epi on board. So we know, okay, evolutions, everybody's paying attention. We've got an epi on board, we're continuing CPR, we've got an airway, now we're establishing an airway. That could be an eye gel, that can be an ET tube. Well, remember, we want to protect that. And what's another consideration we want to think about this person? How long were they in the pool? We're going to start thinking about putting an NG tube down there because we're going to start getting that compression spacing in there that happens when they're filling up with air. We want to release that air. We have that suction standing by. When we expect to get ROSC, we're hoping to get ROSC. They might start vomiting. We're going to have a suction by. Multiple hands doing multiple work with one goal in route, and that's to get this patient back to breathing on their own.
That NG tube is such a critical consideration for a pediatric patient because, again, that big toddler belly that we all see that's so cute is because they don't have that same muscle wall formation. And so if they get that abdominal distension, it really puts a lot of pressure into the chest and decreases the efficacy of your ventilations. And our singular priority focus for this patient needs to be effective ventilations to ensure effective oxygenation. And so decompressing that belly is one of the, not a priority intervention, but certainly an important consideration, cannot be forgotten on scene. We have to make sure that we're doing that for all the pediatric patients, especially a drowning.
We're constantly evaluating. There's so many things little things that we want to do to affect this. As soon as we're loading in, Native Air is also going to start thinking about blood sugar, right? We start going through all that stuff. That patient in that struggle to drown could have burned through, their sugar could be at 45 right now. Obviously that's down the line from the airway and the brain and the circulation, but all those little things to help improve that patient's condition, to quickly get them where we need them, and also when they get to the hospital, set them up for success.
Any of the interventions that we do on scene have to be balanced between what the patient needs and how quick can we move him.
So there we go. We had the child in the pool. Unresponsive, outstanding work by the lifeguards. Everything we would want to do. Phoenix Fire showed up. We continued on that. We built on what they built. We're all building this together. So now, we always say in EMS and pre-hospital, transport is treatment, right? That's one of the key components for us. We don't want to be on scene too long, but we want to get it done right. But transport is treatment. Now this person needs to get to a higher level of care. We've got them stable to the point of airways established, we have an IV established, and then Native Air will probably have a few things they want to check off before they lift off with a critical patient.
So one of the things that we bring is a higher level of care with chest tubes and an advanced ventilator and blood, but obviously our biggest asset that we bring is speed. And so we can get this patient to a specialty pediatric center. He could be at PCH in about 7 minutes, 6 minutes from here, pretty quick, especially when we fly over Sky Harbor. If we have a really critical patient, we can actually call ahead and the tower will clear traffic sometimes, depending on the time of day, so that we can just fly direct and we don't even have to go around for all of the big commercial airliners coming in. That saves us about 2 minutes. So for a patient like this, they would probably call for life flight to get us as quickly as we could so that we can get him to those specialty resources. That's especially important when we think about burn patients, pediatric patients, getting them to those downtown specialty resources when they're on the outskirts of town is something that we can do really quickly. Getting him secured in the aircraft.